It's a pleasure to be here. I'm Dr. Katie Kompoliti from Rush University Medical Center, and I am here to discuss dysautonomia and multiple system atrophy. So the dysautonomia refers to the involvement of the autonomic nervous system in multiple system atrophy, which is the part of the nervous system that controls a lot of our body, and it's mostly outside our will. This dysautonomia involves orthostatic hypotension, bladder dysfunction, constipation, erectile dysfunction, and thermoregulation. So we'll start with blood pressure control, and their blood pressure is controlled by different mechanisms in the body, and part of it is the autonomic nervous system, which we're going to discuss today. And but that's not only the only part of the blood pressure control. It involves an elaborate network of receptors, nerves, and hormones. So the autonomic nervous system is consists of the sympathetic nervous system, which has been named the fight and flight response, is what gets activated when we get excited, afraid, or when we exercise. And this raises the blood pressure. And the parasympathetic nervous system, which is otherwise called the rest and digest part of the nervous system, and that lowers the blood pressure. And as you see here, the green is the parasympathetic, and the orange is the sympathetic nervous system, and they basically control every single organ in the body. So what is orthostatic hypotension? Orthostatic hypotension is a sustained decrease in systolic blood pressure of 20 millimeters of mercury or more, or a decrease in the diastolic blood pressure of 10 millimeters of mercury or more. That should be observed within 3 minutes of standing, and when compared with blood pressure from the sitting or supine position. Orthostatic hypotension can occur because of different issues. When we are dehydrated, it can be a side effect of drugs, most commonly antihypertensives, or other causes, but what we're going to deal with today is the so-called neurogenic orthostatic hypotension. So the neurogenic orthostatic hypotension, and this can be a little bit complicated here, and I'm not going to test you on neuroanatomy, but it can result from problems in the central nervous system versus the peripheral nervous system. The central nervous system is what's within the membranes that cover the brain and the spinal cord, and the peripheral nervous system is the nerves, whatever is outside that. The only reason I'm bringing that up is to make a point, which I'm going to come back to later, that multiple system atrophy related neurogenic orthostatic hypotension is usually driven by problems in the central nervous system, as opposed to Parkinson's disease, where the problem is more peripheral than central. So when we stand up too fast and our blood pressure stops, people can have multiple diverse symptoms. Some of them are non-specific, like weakness, sleepiness, fatigue, falling, nausea, or leg buckling. Or they can have symptoms from cerebral hypoperfusion, like dizziness, lightheadedness, presyncope, or syncope, i.e. loss of consciousness. Sometimes episodic confusion when the blood pressure drops, or headache. And from decreased perfusion or blood supply to the eyes, we can have blurred vision. We can have the so-called coat hanger headache, which is very characteristic of low blood pressure, which involves the neck and the shoulders. If the heart doesn't perfuse, we have angina, or when the lungs don't perfuse, we have shortness of breath when we stand up. So what happens when we go from the supine position to standing? More than 500 ml of blood, half a liter of blood, goes into the lower body. In a healthy subject, there are normal compensatory mechanisms that help push the blood up to the vital organs, including the brain, and maintain perfusion. And this happens through norepinephrine, which is part of the sympathetic nervous system that helps maintain the blood pressure and the heart rate. In patients with neurogenic orthostatic hypotension, there is insufficient norepinephrine response due to autonomic dysfunction. So the person stands up and the blood cannot pulse in the lower body and doesn't go up to where it is needed to maintain vital organ perfusion. And this is a normal day. And you see the green is a normal person. And you see you have blood pressure fluctuations throughout the day. And at night, the blood pressure goes down. In a person with NOH, so you have bigger fluctuations throughout the day. And when the person lays down at night, the blood pressure goes up instead of down. So we're dealing with a roller coaster. So what makes the blood pressure go down even more, besides standing up, assuming the upright position? Meals can do that in a very dramatic fashion, as you see here with the red lines. And that's because a lot of blood pools in the abdominal area. And at night, what can make it deep is when people get up to urinate. And the blood pressure you get in the morning when you wake up, before you get out of bed, is the highest it can be. And that's an indication of what we call supine hypertension. And you see that person gets out of bed and has a very dramatic dip in the blood pressure. So this is one of the worst times. So what do we do to treat NOH? We discontinue the offending agents like blood pressure medications, old-fashioned antidepressants, medications for erectile dysfunction, bladder medications, and tizanidine, which is a muscle relaxant, is a hidden offender usually. We institute other conservative non-pharmacological measures. And finally, if all this doesn't work, we resolve into pharmacological treatment. So some of the lifestyle adjustments we do are advised to avoid hot, humid weather, to avoid hot showers, saunas, prolonged bed rest during the day, physical immobility, high carbohydrate meals, especially meals with high glycemic index, carbs, and daytime alcohol. We encourage exercise in the recumbent or seated position, like rowing or stationary bike. Exercises in the pool are appropriate, and frequent smaller meals as with low glycemic index carbs. So here is the glycemic index, and you see like everything that's bad for you but tastes well is in the high glycemic index territory. And as you go to the left are the foods with the low glycemic index. So moving on, another thing we insist upon is volume expansion. We advise people to avoid alcohol, caffeine, and sugary beverages, encourage increased fluid intake, salt liberalization for those people who don't have the supine hypertension. And then when somebody feels fainty, all you need to do is sometimes give them an acute water bolus, especially with ice. So ice water, 500 ml acutely, corrects the blood pressure for an hour. Or if you're not afraid of supine hypertension, you can do you can add salt in it. Physical maneuvers that can maintain the blood pressure when you stand at the supermarket line are shown here. People should avoid straining with closed glottis, which you do usually when you strain to have a bowel movement. That's called the Valsalva maneuver and can dramatically decrease the blood pressure. And we encourage changing positions gradually, briefly sitting before standing. And as I said before, when you're standing somewhere, a brief leg crossing, standing on the tiptoes, stooping, squatting, or buttock clenching can adjust the blood pressure. Compression garments, we should avoid knee-high compression stockings, even though they're easier to put on, but they're mostly placebo. The ones that work have to be at least 15 to 20 millimeters of mercury and be waist high. Another thing that's easier to do and people can use intermittently, especially after you eat and you have low blood pressures, is an abdominal binder. And you can buy them easily on Amazon. So 50% of patients with NOH have supine hypertension, and that's worse early in the morning, as I showed you before in the graph. And that probably results from pressure diuresis having during the night when you go to the bathroom and volume depletion. So what we insist upon is elevating the head of the bed at least 30 degrees and avoid nighttime meals and sweets. And also we should tell people not to take medications to raise the blood pressure like midodrine closer than 4 hours before bedtime. If sometimes we want to treat that, we use short-acting blood pressure pills at bedtime, the ones who work during the night and are gone in the morning when you wake up. And some of them are listed here. So from all the medications we have to treat the neurogenic orthostatic hypotension, only 2 are FDA approved, midodrine and droxidopa, and the other ones are available but are not FDA approved. So they all work in different mechanisms, and I'm going to go briefly over that. I know there is another lecture as well, but repetition is good for learning. So having different mechanisms helps combine them sometimes, so you attack the problem from different angles. Florinef, which is fludrocortisone, it's the first one usually we use, retains water through retaining sodium from the kidney. So increases the intravascular volume. And it's kind of mild. So you start with 1 pill, go to 2 pills. If that doesn't work, it won't work. And usually can cause ankle swelling and low potassium. And usually we shouldn't use it for more than for long periods of time, because you can have some effects on the heart and the kidneys. And this is also a complicated cartoon, but it aids me to show you that the rest of the medications I'm going to talk about works at different parts of the system. And the system to the right, the ones to the right, all act on norepinephrine. The sympathetic nervous system, and the one on the left acts on the parasympathetic nervous system on acetylcholine. So the ones that act on norepinephrine, they include midodrine, droxidopa, atomoxetine, and I'm going to come back on those. And ampreloxetine is the one that is currently in clinical trials for MSA. So the midodrine basically constricts the wall of the vessels. It's been approved since 1996. It's very short acting, but it acts very fast. That's why a lot of times we use it as a rescue medicine. So if we need acute onset of effect. And and of course, because of that, it has the worst supine hypertension from all of that. It's short acting, and it has to be dosed 3 times a day, but it shouldn't be taken, as I said before, closer to 4 hours from bedtime or laying down. The next one is Northera or doxidopa, which is a norepinephrine precursor. It gets in the body, it becomes norepinephrine. It's been available in Japan since 1989, but it's been approved in the US in 2014. This is also short-acting, but has a smoother peak. So maybe it has less supine hypertension. And the best response is in patients with low norepinephrine. And finally, the medications like atomoxetine, and which is used now for ADHD, and ampreloxetine, which is in clinical trials, what they do is they recycle norepinephrine and make it back into the synaptic cleft and make it available for action. And patients with MSA are felt to be the most suitable for that. And because as you see here, you remember I said that in multiple system atrophy, the problem is in the brain, is more central, as opposed to Parkinson's disease, where it's peripheral. In patients with MSA, usually you have high norepinephrine, high catecholamines. So, and that means that medications like ampreloxetine or atomoxetine have a substrate to act upon, as opposed to Parkinson's disease, where the norepinephrine is low and there is nothing to work on. So that's why perhaps we think that ampreloxetine failed the trials for Parkinson's disease, and we're very hopeful it's going to be useful for MSA. I'm going to move on for the sake of time. So finally, the only medication we use that works on the parasympathetic nervous system is mestinon or pyridostigmine, and that enhances the cholinergic transmission, but it has a modest effect when used alone, and it's usually like third or fourth drug we add to the cocktail where the symptoms are refractory. So I'm going to move on. That was a brief overview of the blood pressure issues, and I'm going to move on to the bladder involvement in MSA, and that presents as frequent urination, urgency, incontinence, or retention. So what does the bladder do? The bladder is an organ that does two things. One is storage, and the second is voiding. So storage, to achieve storage, the bladder relaxes its muscle, the wall, and contracts the sphincter, the outlet, so the urine doesn't escape out of it. And once it's full, you have voiding, where the wall of the bladder contracts and pushes the urine out while the sphincter, which is the outlet, relaxes. So bladder involvement in MSA can be the only manifestation in almost 20% of patients. And here you see other depiction of the bladder wall and the outlet, the sphincter. And sometimes it can happen 2.8 years prior to motor symptom onset and affects both storage and emptying function of the bladder. And in early disease, you have more overactive muscle tone of the bladder and the weakness of the external sphincter. And you have more frequency and incontinence. And in advanced disease, you get retention when you cannot open the bladder efficiently. And one thing that you can see in the urodynamic studies that's characteristic of MSA is the so-called open bladder neck, which result from loss of sympathetic tone. And this is very characteristic for MSA, provided that the patient has not had surgery to the bladder outlet. So according to the currently accepted criteria for the diagnosis of MSA, if somebody has unexplained voiding difficulties, that means that you don't have another problem with obstruction of the outflow or prostate enlargement, etc. If you have post-void residuals more than 100 ml, that can be consistent with the clinically established MSA, or any volume of post-void residuals that's consistent with clinically probable MSA. And another symptom is unexplained urinary urge incontinence, again, in the absence of urinary tract infections, pelvic surgery, or pelvic floor prolapse. And this is a lower, this is used as lower evidence as opposed to retention, to the post-void residuals. So what are the treatments for bladder dysfunction? Behavioral modification, pelvic floor therapy, medications or procedures. Behavioral modification involves timing of voiding intervals, pelvic floor physical therapy, and avoiding bladder irritants. I'm going to come back to that. Medications here, some of them work on the parasympathetic nervous system. They block the parasympathetic nervous system, and some of them block the sympathetic nervous system. You have to be careful with the bladder medications, and I'm not going to go too much into this, but some of them, like the anticholinergics, worsen cognitive function, and others, like the alpha antagonists, lower the blood pressure. So people with a severe NOH should not be on Flomax, for example, which is a very common medication people take for bladder dysfunction. On the other hand, B3 agonists, unfortunately, they can be expensive sometimes, like mirbetriq, do not affect either cognition or blood pressure, and they're usually a good choice. And finally, when we want to attack things from multiple angles, there are medications that help with the prostate issues because, MSA patients are not immune to prostate enlargement given the age range where the disease appears. And these are some medications we use for prostate problems. And finally, procedures, which are always welcome, given the fact that, they don't act in your brain and they don't make you more confused or lower your blood pressure, include botulinum toxin injections, nerve stimulators, intermittent self-catheterization, sometimes in people with severe retention, or permanent either catheters, Foley catheters through the urethra, or suprapubics. And finally, prostate surgery, as I said before, to help solve some of the other issues. So bladder irritants are listed here and should be avoided, include alcoholic beverages, citrus juices and fruits, spicy foods, caffeine, carbonated beverages, sugar, honey, corn syrup, artificial sweeteners, or smoking. So I'm going to move on to the GI system in multiple system atrophy, and the two main symptoms here are constipation and gastroparesis. Gastroparesis refers to the symptoms that result from slow movement of the stomach, which results in slow emptying and early satiety. But I'm not going to talk about that today because it's a big subject. I'm going to talk about constipation a little bit. And constipation in MSA results from disordered movement of stool through the colon or the rectum. And this can happen from multiple reasons. And but here the one we are talking about today is due to disease, which is in this case MSA. But you should look into drugs and make sure that you're not making the problem worse. Some of the bladder drugs, for example, can make constipation worse. So it's a never-ending problem. So here again, like with the bladder, we have non-pharmacological treatments like increased fiber, change in diet, exercise, squatty potty can be very useful, and hydration is always imperative. You have to drink a lot of water. And then we have different medications like bulk forming laxatives like metamucil or fiber cones, stool softeners like Docusate, the ones that promote water secretion like Miralax or lactulose, stimulants, we don't use those a lot in our diseases, serotonin promoters, and motegrity is used for gastroparesis as well. And the fatty acids, the newer ones that work quite well, can be expensive often. And then don't underestimate exercise for the treatment of constipation, even not so too many of us can do these poses. Erectile dysfunction can also result from many reasons. It can be psychological, it can be hormonal, vascular, drug-induced, or associated with aging. But in our case, we're referring to the one that results for problems in the central nervous system. And in a sense, we treat them mostly the same. And one has to be very careful because the drugs that we use for erectile dysfunction can lower the blood pressure. So you have to be really careful with that. And finally, I'm going to touch upon thermoregulation. Thermoregulation refers to the absence of sweating or reduced sweating. So if you don't sweat, you have decreased ability to dissipate heat, heat intolerance, and increased risk of heat stroke. Patients can have cold hands and feet, and very rarely can have either fever, hyperthermia, or hypothermia. So what do we do? A lot of this is common sense. I keep coming back to hydration. We need to maintain hydration, especially in hot, humid days. Avoid sugary drinks. Again, a repeating theme throughout my talk. Stay in the shade or indoors during hot weather. Apply a cool, damp cloth in the neck or other pulse points, or use those portable fans. Wear light, breathable clothing, preferably cotton or linen. And in cases of hyperthermia, use rapid cooling measures such as external cooling pads. So basically, just learn how to avoid extreme temperatures. People are mostly bothered by extreme heat in this disease. And with this, I'm going to conclude my talk today. And there's going to be a separate question and answer session. And thank you for allowing me to be here. And I feel privileged to be part of treating this community.